This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken only with prior written consent of the AARC. Copyright 2011, all rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services, and I welcome you to today's webcast on respiratory care of the morbidly obese patient. Upon completion of this AARC webcast, participants will be able to discuss the physiologic effect of morbid obesity, describe the relationship of obesity and asthma, discuss effective ventilatory strategies for the morbidly obese patient, and cite the latest evidence-based research. I am pleased to introduce today our speaker, John Davies. John is a registered respiratory therapist and an AARC fellow. He is the clinical research coordinator in the Department of Respiratory Care at Duke University in Durham, North Carolina. John is a published author and recognized expert in the area of mechanical ventilation. Mr. Davies discloses that he has no disclosures related to this presentation. Any brand names may be mentioned only as examples of technology. John, welcome to the program.
Well, thank you, Bill. Get this going. Okay, thanks, Bill. I'd like to thank all the participants for taking time out of their busy schedules to participate in this webinar, and I hope you'll find this both interesting and informative. Get my pointer ready here. First time with my hand pointer. So I'm going to talk about the background of morbid obesity, why we're concerned about it, the physiologic effects of morbid obesity, the influence of obesity on mortality. That's an interesting topic, and ventilatory strategies that we can and probably should be using on these patients. So the obesity categories, if you look at on the far left, this is the normal, and BMI is anywhere from 18.5 up to about 25. Overweight is considered 25 to 30, and I'll show you in a second how to calculate the BMI. But just kind of remember these numbers. 25 to about 30 is considered overweight. 30 to 35 is considered obese. 35 to 40 is severely obese, and anything above 40 is considered morbidly obese. So in order to measure obesity, the common way to do it is with body mass index, and it uses weight and height determinants. So it's kilograms per meter squared. So if you, however tall you are, convert that over to meters and square it, and then put your weight on top of that, and that will give you the numbers that I was referring to back in the previous slide. And we don't have to disclose what everybody's BMI is. The one thing I want to point out, though, it doesn't account for muscle mass. If you look at this guy, that actually wasn't me in college, but this guy is probably, if you just looked at BMI alone, he would be morbidly obese. But certainly this guy is in better shape than probably everybody here. So when you think of athletes, you know, the Michael Jordans of the world and people like that, it probably doesn't apply. So the muscle mass does figure into the equation, but it should not be considered obese. Why are we concerned about this? If we look at the trends in the U.S. from 1990 up until 2009, down here at the bottom you see what they're saying is that in this one here, less than 10%, that means that less than 10% of the population is considered obese. And remember, obese is 30 to 35, and so with the BMI. So this Tar Heel blue here is less than 10%. The darker blue, 10 to 14. The Duke blue is 15 to 19. Then you get into tan, that's 20 to 24. And then you get this red or orange, I guess, 25 to 29, and then above 30 is the red with the dots. And you can see going from 1990 to 1999 to 2009, there's been a huge increase in the obesity rates. And I think I read something the other day that said that there's now 12 states that have obesity levels of over 30%, or over 30% of the population is considered obese. And you can look at this and identify where your state is. And being where I'm from, North Carolina, we're not bad yet, but we're surrounded by a bunch of states that have high obesity rates. And the trend is disturbing because it keeps getting worse. So the obesity epidemic, it's now estimated that a BMI of 30 to 40, remember that's obese and severely obese, that 25% of the population is in that category now. Morbid obesity, 5 to 7% of the population, and then with a BMI of less than over 50, 1 to 2% of the population is what they call, some people call super obese. But if you look at this 5 to 7%, it doesn't seem like a big number until you factor in 5 to 7% of the population of the United States, whatever it is, 300 million. That's quite a number of people, and they all tend to have, health complications associated with obesity. So it is a difficult thing to deal with, and it's not going to get better anytime soon. It's been estimated that 300,000 patients die each year from complications associated with obesity, and that 10% of the U.S. healthcare expenses, which is, well, this was a few years ago, $100 billion a year, was associated with obesity. And in the last decade, it's increased by 50%. Now, I'm not sure how this factors into the debt ceiling debate, but certainly the healthcare reform, I'm not sure how they're going to tackle this, but certainly it's something that we have to take into account, and it's not going to go away anytime soon. And you can see the hospitalization rates are 2 to 4 times higher in this population. You look over here at this graph, and this is the increase in costs. And the black bar here is obesity, and these are services and medications. And you can see that services are higher. The increases have been highest with the obese population. This is the aging 30 to 50, current smoker, heavy drinker, and then past smoker. But look at medications. The increase in cost is pretty substantial, second only to aging from 30 to 50. So this certainly has a tremendous impact on our healthcare system. What about congestive heart failure? Extreme obesity in itself is a risk factor for heart failure. 30% of, in this study, this was done back in 2002, but I think it's still is, just today, 30% of patients with obesity had impaired LV function cardiomyopathy. So that's a significant number when you think about that. And any of you that have had to deal with patients with morbid obesity in your ICUs or on your floors know that these patients have impaired LV functions. And it's been estimated that for each increment of like 1 BMI, that the risk of heart failure increases 5% for men and 7% for women directly. And then you also get an increase of risk of heart failure due to things that are caused because of obesity, like hypertension, diabetes, and hyperlipidemia. So it's associated with a lot of bad things that are going to affect other organ systems. And even this study was done back in 2006, and it was a retrospective look, but they looked at the association of obesity and mortality. And the number that really strikes me is that first one. Say that they estimate that if your chance of mortality increases 40% if your BMI is greater than 25, and especially if you're over 50 years old. So they're saying if you're old and you're obese, the chance of mortality is much higher. And certainly if your BMI is over 30, then you're 2 to 3 times more likely to die from something associated with obesity than the normal person. So certainly a huge impact that these patients are going to have. In general, if you want, and we could go into all the other effects, but there's not enough time in this talk to do that. But in general, morbidly obese patients suffer more complications, a higher health risk for various syndromes, cancer, gout. There's many things that can happen. Longer hospital stays, more days of mechanical ventilation, and you would think higher mortality rates, and as we saw in the previous slides, a lot of people estimate that they do. However, there's been some studies come out recently that are somewhat counterintuitive, and we'll talk about that a little bit later. So I'll continue on with the physiologic effects of obesity so we can understand what's happening to the lungs, the chest, and the body, and how we can effectively ventilate them. So patients that are, if you look at the top here, this is a normal patient. And this is you and I, everybody else breathing here. Tidal breathing, you develop large cyclical strains on your airway smooth muscle cells. And this is important because it keeps them compliant. The bigger the breaths, the more they have to, just like any type of muscle, the more it has to stretch. And so they become compliant, and airways, so then they become long, and they get what they call a large airway caliber, which is what you want. You want compliant, responsive airway muscle. With the obese patient, you have a decrease in FRC, and I'll show you that in a second here. You have decrease in parabronchial pressure, but more importantly, because of your FRC, your tidal breathing goes down. And what does that do? Your cyclical strains on airway smooth muscle is now reduced. The airway cells, smooth muscle cells themselves, become stiff, and so that further reduces the tidal breathing because you don't have the large airway caliber. The cells are not as long, so they can't respond to take deeper breaths. So it's kind of a vicious circle. And here's what happens to your volumes. If you look on the left-hand side over here, you can see that here's your FRC. This is a lean person. Here's your airway smooth muscle cells. You can see that they're relatively long, and the airway lumen is fairly large. If you go over to the obese patient, the reduced lung volumes, you can see that it's mainly FRC, and ERV is mainly responsible for that. So you have a reduced FRC, your cells become smaller, they can't stretch as much, so what's going to happen is your lumen is now going to become smaller. And this will be important when we start talking about airway resistance and things like that. So that's essentially what happens to these patients. They have a reduced lung volumes, especially FRC, and we all know what the FRC is important for. So that's what these patients are going to suffer from. And it's been estimated from a study done a few years ago that for each unit increase in BMI, the FRC decreases by 3%. That's only for one unit. And ERV decreases by 5%. So if you're 5 units obese, then that's 15% and 25%. So fairly significant reductions in volume can exist with the obese patient. So what impact do low lung volumes actually have? And certainly we saw that breathing at low tidal volumes, so you're going to have smaller tidal volumes. Perhaps they can breathe a little bit faster to maintain their minute ventilation, but many times they can't because they don't have the muscle mass to move the chest, so they end up with hypercapnia. And we've seen this in a lot of, if anybody, you all have probably had to deal with the morbidly obese patient, and they all have kind of COPD-like blood gases, with the elevated CO2s and elevated bicarb. But as FRC decreases to near closing capacity, that's when you start getting in the area of actually airways that will close during regular tidal breathing. And you end up with underventilation and intrapulmonary shunting and ultimately hypoxemia. So a lot of bad things can happen. And that's what the morbidly obese do suffer from. What about the mechanics? What happens to the lung mechanics in these patients? Certainly, you get a reduced lung compliance because you've got decreased volume, you've got small airway collapse, so you're going to have a reduced lung compliance. The other thing that happens is that you get increased blood volume in the pulmonary circulation. So that increased volume is also going to help contribute to decreased compliance. You also have, which is pretty obvious in these patients. You're going to have a reduced chest wall compliance, and because of all that adipose tissue. And so you're going to have, it's certainly going to be more pronounced in the supine position. But moving these patients around, trying to get them in the optimal position is also a challenge. Okay, so compliance. Let's look at the components of the compliance here. Over on the right, you're going to see a representation of the lungs and the thorax. The compliance that we usually see in our calculations is the compliance of the respiratory system in total. But it really makes up the lung compliance, so just strictly lung tissue, as well as chest wall compliance. So those two contribute, added together, give you the compliance of the respiratory system. So especially with these patients, it's important if we can figure out what is this chest wall compliance, because you would think that in these patients it's going to be quite low, and what is the actual lung compliance? What do the lungs actually see? So here's a study. It's a little bit old, a little bit dated, but it applies. It was Pelosi looked at 24 patients, 8 of them that were normal, 8 overweight, and 8 that were considered morbidly obese. And I'm sorry, that's the second study. This one was I think 30 patients. But anyway, it's a group of patients of varying body mass index. And what you're seeing at the top here, this is the compliance of the total respiratory system. Here's your BMI. So you can see that at 20, and then you get down to 30, you can see the compliance of the respiratory system declines as the BMI goes up. Here's the compliance of the lungs themselves, and here's the chest wall down here. And you can see that BMI, here we are at 20 again, the chest wall is a pretty linear reduction in compliance. But what's very surprising is if you look at the lungs, the decrease in lung compliance is pretty dramatic, from between even just 20 and 30. And then it kind of smooths out after that, and then above, I would say, 30 to 35, it looks like the majority of it is chest wall compliance, but that decreases. But it is worthy to note that lung compliance is a key factor in this. It's not all chest wall. And how they did this is they had if you put an esophageal balloon down, and I'll show you this later in the lecture, you can actually estimate pleural pressure, which corresponds kind of indirectly to chest wall pressure. So you can kind of take the airway pressure, subtract the pleural pressure, and that should give you what the lungs actually see. That's how they did this, even back in 1998. But you can see it's a combination. It's chest wall and it is lung compliance, not just chest wall compliance. Now, if you were looking at on a ventilator, and this would be a normal patient here, this is flow, and with an inspiratory hold. This is tidal volume here. This is your airway pressure. You can see there's your peak, and then you've got a plateau pressure here. And this is esophageal pressure. So in a normal patient, you will get a plateau pressure with esophageal pressure as well. What happens to the obese patient? Well, really nothing will flow if you're this looks like it's volume ventilation, and nothing happens to the flow, nothing happens to the volume. You do get a spike in the peak pressure, and you also get an increase in plateau pressure. So the plateau pressure basically gives you the static situation. So you can say, well, geez, there's a decrease in compliance. There's not resistance here. This is compliance. But look at the esophageal tracing. It has gone up. So looking at it from that perspective, you can say, well, the plateau esophageal here, a lot of this patient, it appears to be a lot of it to be chest wall compliance that's decreased. So that's what you would see if you had this actually on a ventilator, or it was called the Bicor back in those days, that measured esophageal pressure. And this is a patient from a study a few years ago, but I like this slide because it shows you down at the bottom, you're looking at a patient. This is before induction of anesthesia. This is a normal patient. This is after extubation, and this is 24 hours after. And you can see that there's pretty good lung volumes, somewhat normal chest wall. if you look at this as an obese patient, this is not even a morbidly obese patient, this is just an obese patient, you can see that the chest wall is, the thickness of the chest wall, indicating that there's lots of tissue, adipose tissue around the lungs. And you can see here after extubation. Now here, it looks like there's, the lungs are pretty well expanded, but here you start to see some atelectasis over here and over here, and even 24 hours later. And in this study, they did show that there was a large increase in the obese population in terms of having post-surgery atelectasis with the obese population, especially some of the morbidly obese ones that they did. But I just thought that looking at a CT of these patients, you get an idea of what they're having to deal with even to try and breathe normally. So what about lung airway resistance and lung mechanics? Remember that there was a change in airway caliber, so you've got a narrowed airway. You also have, and this is becoming big in the literature, it's looking at systemic pro-inflammatory mediators, and there is a study ongoing, or I think it's still ongoing with the NIH, looking at some of these pro-inflammatory mediators in using omega-3 fatty acids to try and reduce these levels. But in any event, it's been shown that there's an increase in these pro-inflammatory mediators. Interleukin-6, C-reactive protein, two of the bigger ones. And so this is kind of important, because we're going to talk about the association with asthma, and there's some theory that maybe these systemic pro-inflammatory mediators actually contribute to the patients getting this adult onset asthma. But we'll look at that in a second. You get actual remodeling in the airways from what's called pro-inflammatory adipose cytokines. So there's direct remodeling because of the obesity and the airway muscles, airway smooth muscle, and there's direct damage, repeated opening and closing, because remember you've got a lot more areas of microatelectasis and things like that, so repeated opening and closing during tidal swings can damage the lungs directly. So here's the same study of Pelosi's, and same method. You looked at, this is the resistance of the respiratory system, and this is the resistance of the lung, and this is the resistance of the chest wall. Now, the total resistance here, it's obvious by looking at the chest wall that the chest wall has relatively little input into adding to the resistance. It's mainly the lungs here. So the lungs, the airways shrink, some collapse, they reach their critical closing pressure, and you get this increase in airway resistance. Which, let me just go back to that slide. When we come to talk about asthma and its relationship with the morbidly obese, it's this that we're concerned about, and again, what we'll try and look at is whether it's truly asthma or whether it's because of this remodeling and the airway caliber, things like that, that's causing the so-called wheezing and not asthma per se. So anyway, compliance and resistance. The morbidly obese patients, they have an increased work of breathing, and we've all seen it. They struggle to breathe, both the weight of the chest, compliance, resistance. But it's been estimated that the increased work of breathing, 55% of that's due to decrease in lung compliance, 30% in chest wall compliance, and 15% due to pulmonary resistance. So you've got a number of factors going on here that these patients have to deal with. So to kind of summarize the effects on the respiratory system, you get the low lung volumes, which gives, and decreased compliance, which leaves these patients prone to atelectasis and airway closure. You get increased resistance in the airways. You get chest wall resistance that's basically unaffected, which is not surprising. You get increased work of breathing, and the result of that, you get expiratory flow limitation, and you can have intrinsic PEEP and dynamic hyperinflation, and those are two of the key words when you think about patients with bad COPD. You get intrinsic PEEP because they have small airway collapse, and you end up with dynamic hyperinflation. So these patients can exhibit a COPD type of and an asthma type of scenario. And a lot of times these patients do have both. They have the morbid obesity effects and they have COPD from long years of smoking and things like that to kind of compound the issue. So as I said, breathing at low volumes is going to promote airway closure and atelectasis, expiratory flow limitation. And it also, if you read the literature, it says it increases the risk of adult onset asthma. And that's what I'm going to talk a little bit about now. Does it really do that, or is it just the effects that we're seeing from increased airway resistance? So this, excuse me, is a meta-analysis that was done a few years ago. 6 studies that looked at the relationship between obesity and asthma. And for those of you that are not familiar with a meta-analysis, they kind of weigh out all the information, and then they have an odds ratio at the bottom. So anything to the right of 1 indicates that there is a relationship between the 2 variables that you're talking about. So in this case, obesity and asthma. If it was to the left, it would be a negative association. So there would be no interaction between them. So in this case, we're looking at overweight patients. And remember, the overweight's only 25 to 30 in terms of BMI. You can see that there is a positive relationship, and the odds go up that these patients present with quote-unquote asthma if they're overweight. We shift down to the obese population, so 30 to 35 and above, you can see that there's even more of a risk of getting adult onset asthma from these studies if your BMI is 30 to 40 and higher. So there's certainly, from this study, if you look at it this way, certainly seems to be an association between obesity and asthma. And as you might expect, the literature, there's been a total of 13 prospective studies that I'm aware of up till now, and all of them but 1 showed a greater incidence of asthma in the overweight and the obese population. And I will say that you don't find a lot with just strictly morbid obesity with these patients, because they study obese patients, but the morbid obese patients, if you look at a lot of the NIH studies or any studies, one of the exclusion criteria is a BMI of more than 40. So there's not as many studies out there as you might think of morbid obesity. There's a lot of studies that look at obesity, but not specifically morbid obesity. But I think you can take this and say, well, if this happens in obesity, it's going to happen with the morbidly obese as well. So it certainly seems like it's got a positive association with asthma. I'm going to ask the question, is it really asthma? I want you to think about what is the definition of asthma. It's FEV1, it's some PFTs they're variable. I mean, if you look at, for those of you that do PFTs, I mean, these patients, it's a lot of it's dependent on the patient, how they feel that day, their effort. So it's kind of a differential diagnosis in some sense of the word. So is it really asthma? If you look at the morbid obese patients, lung volume changes and increased resistance. Well, that can happen with asthma. The pulmonary blood expansion can lead to congestion and a direct edema of the airway wall, which will increase resistance. And this, by the way, this also increases the airway wall thickness, which further creates increase in resistance. You also get a release of humoral regulators, as I mentioned. And it leads to a pro-inflammatory state. So people think, well, we get these inflammatory responses in asthma. Is it, tumor necrosis factor alpha? Is it IL-6? Is it C-reactive protein? That's what's really not known yet, whether there's a direct effect. But certainly the physical effects of morbid obesity can lead to asthma-type effects. So these 2 guys, in a couple recent studies, tried to look at the link between systemic inflation and what they call localized neutrophilic airway inflammation, which is what is kind of the cornerstone of asthma. And they were not able to directly link the different pro-inflammatory mediators that are systemic to what causes asthma. I think Scott's study, if I remember correctly, there was an increase in the female population, or more of a direct link. It wasn't direct, but more of an association that some of those pro-inflammatory mediators were found in the lungs. So that's still under study. So, but as of right now, there's no direct link between the systemic pro-inflammatory mediators and the lung pro-inflammatory mediators. And I find these interesting. There's 3 studies that show that asthmatics have less of a response to standard therapy. And these are all recent studies. And so if they have, and they looked at a number of different, obese asthmatics versus the normal asthmatics, and they concluded that they had less response to the same therapy. So that would lead me to believe from that maybe it's strictly the physical changes of morbid obesity and perhaps not asthma per se, but we still don't know that. And this bottom study just came out, and they looked at these patients that underwent bariatric surgery. They looked at their asthma-type symptoms previous to the surgery and then after, and they showed with no change in the medication regimen, they showed that there was an improvement in the asthma, quote-unquote, type symptoms after bariatric surgery. So again, that would suggest that maybe it's the actual physical changes that happen with the morbidly obese patient and not so much a specific asthma diagnosis. But again, we don't know for sure. So what about, I was talking about the influence on obesity on mortality, and it's kind of counterintuitive, but we'll look at some of these studies. This is a study from a few years ago looking at trauma patients, and this over here, this is the percentage of patients underweight. The white bars represent patients that did not require ventilation, and the black is the percentage of patients that did require mechanical ventilation. Underweight is fairly low in both cases. Normal patient, most of them did not require, or the majority of them did not require mechanical ventilation, but as you get to overweight and as you get to obese, you can see that the percentage that required mechanical ventilation increased in the larger that the patients were that came in. So certainly that would suggest that these patients are going to be more at risk of getting mechanical ventilation, and along with that, all the bad things that go along with mechanical ventilation. Chance of ventilator-associated pneumonia, all kinds of things that, longer times on the ventilator, have bypassing the normal defense mechanisms by putting an ET tube in. So there's a lot of issues, plus ventilating them, ventilator-induced lung injury, a lot of things. So you would think that because more of them require mechanical ventilation, you would think that they're more at risk for mortality. So let's take a look at that. So this is a study that was done last year, looked at mortality rate percentage here, and looked at mortality rate underweight, normal weight, overweight, and obese. And you would think that we should shift this x-axis so obese is over here, but in reality, this is what they found. Mortality rate actually decreased the bigger the patients got. Now, granted, if you look at the size of the sample, it's not very big, but certainly seems to be almost a linear trend here. So that had a lot of people scratching their head and saying, oh, what in the world? This is another study looking at obesity and acute lung injury. And what you're looking at over here, and I'm sorry it's a little bit blurry, but you're looking at hospital length of stay. The black circles are all patients. The gray ones are just survivors. But just look at, this is underweight here, overweight, and this is obese, and this is severely or morbidly obese. And you can see that this patient population required a higher hospital length of stay. This is the ICU length of stay. It's higher. Duration of mechanical ventilation is higher. But look at this. No significant difference in mortality with severely obese. So, again, surprising. What about ARDS? This was a study that was done also recently, And over here you're looking at the percentage of patients that developed ARDS, and underweight, normal, overweight, obese, severely obese, and you can see that they're at risk of the bigger these patients are, the more at risk they are of developing ARDS. But again, no significant difference in mortality. So, and this is this is overall mortality. So it's not specifically because they were obese, but it's what we did with them, I think. What about H1N1? That was a big issue a couple of years ago. So this study by Davies looked at patients that had H1N1 and looked at obese patients that had H1N1. It actually has quite a few patients here, N of 265 here in the non-obese and N of 150. But if we look down here, the number of ventilator days for the non-obese, 13.2, 2 days longer with the obesity. ICU length of stay, much longer with the obese patients. Hospital length of stay, much longer. And again, no difference in mortality. We're seeing this cropping up, no difference in mortality. And these are a lot of significant disorders that these patients have had. So just to kind of recap all the studies, now this is a collection of studies that are a little bit older, they don't include all the ones I just showed you, but if you look at this is obesity associated with mortality, and you can see that, yeah, there's a few of them that are associated with an increased mortality, but a larger number that are not associated with an increase in mortality. So there's a lot of confusion about why aren't these patients, it seems to make sense that these patients would have a higher mortality rate because of the condition they're in. So, but certainly the studies don't bear that out right now. So let's look at the ventilation strategies, and I'll throw my editorial in as to why perhaps these patients don't have a significant increase in mortality compared to the normal patients. And so ventilation strategies, this is nothing new for you guys. The patients that have the hypoventilation syndrome, obstructive sleep apnea, non-invasive certainly works great for reversing the muscle load due to all that adipose tissue, and helps patients sleep. It actually helps them ventilate a little bit better, and we'll see that with these patients, if you can avoid intubation by using non-invasive with these patients, it's certainly a big plus, because not only are they a difficult intubation, they're usually, as we saw, on the ventilator longer and things like that. So how do you manage your non-invasive? I think that, it's kind of a mainstay now, especially for COPD and CHF and for obesity hypoventilation. There's no real standard consensus for titration, and I think that I'm not sure we'll see one anytime soon, but I think that I think it's just every patient's a little bit different, and I think that if you follow, say, the pH is acceptable, and you look at the patient, they look like they're not breathing too hard or working too hard to breathe, perhaps just a level of CPAP would be sufficient for them. But if the pH is if the pH is low, if the work of breathing is high, you look at them and you can see them really struggling, then bi-level is probably the best way to go. But again, as I said, putting them on non-invasive is good, but if they have to be intubated, don't try and exhaust every non-invasive option that you have. If you put them on non-invasive and they're not turning around, then probably need to intubate them before it becomes an emergent situation. And there we go. Now, for all those of you that intubate in there, this is the one thing that you do not want to see. Large neck circumference. You have excess tissue here, which is going to obstruct your view. You're going to have a Mallampati of 3 or higher. Probably may not see the airway when you put the blade in. You probably have limited neck mobility. And if they've got a receding mandible with all this, then you might as well get the cavalry in, because these patients, if it's an elective intubation, you can get all the resources that that you've got in your institution. But if you leave it and it becomes an emergent situation, then this can really turn ugly. So it's important with these patients to get proper airway assessment, and like I say, don't leave intubation too late till it becomes an emergent situation, because you may not be able to get that tube in. Okay, we've got the patient intubated. What do you do on the ventilator with these patients? The first thing that I think is that you need to calculate your tidal volume based on ideal body weight, and I think that most institutions do that now. I still remember the days where we would just do it by actual body weight. So if we had somebody that was 500 pounds, they got a big tidal volume, and we know that that's not the right way to do it now, because the lungs don't increase in size. Probably the most important thing is higher PEEP levels may be required, and this to increase the FRC. And I think this is the one issue that a lot of RTs struggle with the docs, because they're not comfortable with you using those high levels of PEEP. I know back in the 80s, in early 90s, we did that. We used super PEEP levels, not necessarily for this, but just because it seemed to improve oxygenation. But we've gotten away from that, and but I would suggest that the PEEP tables that we normally use for, like, say, the NIH for lung protection may not be sufficient for these patients. The minimum stretch strategy, we look at plateau pressures, keeping them 30 to 35. That's a good one if you don't have an esophageal balloon, but again, you don't know how much of that is chest wall compliance that you're dealing with versus what the lung's actually seeing. So esophageal balloon measurement may be something that can be useful, because it will give you the chest wall compliance, which in turn can lead us to getting what the lung's actually seeing, or what's called the transpulmonary pressure. And I think the other thing is, I would not hesitate to put these patients, when you extubate them, back on non-invasive, at least to get them through that immediate post-extubation period. There's some studies out there now that's showing that, the COPD patients especially, but that these patients may benefit from that. And you might be able to get away with an earlier extubation. So this is one of our patients. I forget how much she weighed, but it was impressive. But you can see what I want to show you here is that the lung fields are not any bigger. So dealing with actual body weight is going to hurt these patients in all likelihood. So we should be using the ideal body weight, because that's what you want to get into the lungs. So what about the effects of PEEP? And this is a study showing the respiratory system in a normal patient here. This is the lung, and this is the chest wall. And what they're showing is volume. But I think that if you look at, you can see here, the white circles are no PEEP, and this is a pressure volume curve. You can see that when they add 10 of PEEP, the normal patient, that basically there was no change. There's no hysteresis there, so there really was not much effect from adding PEEP. But if you look at the obese patient, here's 0 PEEP. If we add 10 of PEEP, all of a sudden the curve shifts up to the left, and you've got higher volume. So that would suggest that you've got some alveolar recruitment using only 10 of PEEP, actually. But you can see some hysteresis here, and you can really see it in predominantly the lung fields, not so much chest wall, although there seems to be a little bit, but in the lung field. So the PEEP is, and that would make sense since you're increasing FRC. So it certainly appears that using PEEP will help with your alveolar recruitment. And this is from the same study. They're looking at the resistance of the respiratory system. Normal patient is 7.7. The obese patient, 13.4. This is at 0 of PEEP. And if you add 10 of PEEP, the resistance actually did go down a little bit with the normal patient, but it went down significantly with the obese patient. And so you get this alveolar recruitment. You also get a decrease in respiratory system resistance. So a couple of good things that can be done. So what is the optimal PEEP level? I mean, nobody really knows. Standard methods, as I mentioned, they may not apply if you don't factor in what the transpulmonary pressure is. Erlandson, this guy did a study using electric impedance tomography a few years ago. He looked at 15 patients with a BMI of 49 and came to the conclusion that 15 centimeters of water was the optimal PEEP setting. And I can say that in our dealings with the esophageal balloon, that is kind of what we see too, that we need anywhere from 12 to 18 as the optimal PEEP level for these patients. And keep in mind the higher PEEP levels may require some volume loading. So transpulmonary pressure, okay, what it is, if you look at A, that's the total airway pressure. Okay, that's this here. B represents the chest wall pressure or the pleural pressure. So if you subtract B from A, you're going to get C, which is actually what the lungs actually see, and that's called transpulmonary pressure. You got to do it on a breath hold, but that's actually what the lungs see. How do you calculate it? As I mentioned, this is a esophageal balloon, goes in through the mouth or the nose, sits in the lower area of the esophagus, and it approximates pleural pressure. So that we can use this number to say, okay, well, we think that this is the chest wall pressure. And you can see that it's a breath hold, so it's a plateau, transpulmonary plateau. It's the airway plateau minus the esophageal plateau. And these are normal values in adults, 13 to 18 in the lungs, 8 to 15 in peds. And what I like to point out, this is a patient with ARDS over here. The total airway pressure is 21. So look, only 6 is attributable to the chest wall or the pleural pressure. So lungs actually see 15. The obese patient, now this is the total airway pressure of 40. Now 40, if we saw that, we'd go, oh my God, we got to reduce this pressure. But if you look more closely at a lot of these patients, look at the pleural pressure in this patient, this scenario, 31. That means the lungs only are actually seeing 9. So 40 of pressure, the lungs aren't seeing that. The lungs are seeing 9 as the transpulmonary pressure. So the traditional pressures that we use may not apply, although if you don't have the ability to look at pleural pressures, then you can't really make assumptions. This is a tracing from one of our patients that we did. You're looking at, this is the airway pressure here. This is esophageal pressure. You can see the cardiac oscillations here. And what you're seeing is the airway pressure is 28. Look at the esophageal pressure, 25. And this is a real patient. So this patient had a transpulmonary pressure of essentially 3 centimeters of water. So that prompted us to crank up the PEEP, and the patient actually did surprisingly well after we did that. But this is one of our ventilators, so that's how we did the calculation. A lot of times, though, I will say, going back to this, before I conclude, that this esophageal balloon is not an easy thing to do. It may be difficult to place. It's difficult to identify if it's in the right place. The patient's got to be sedated. If they start making efforts, it makes it difficult to figure out where it is. So there's a lot. It's not an easy thing to use, and so if you're not experienced with it, you may or may not get an accurate reading. But this is one that once you see the cardiac oscillations, then that usually means that you're close to where you need to be. Here's something that's gained a lot of attention over in Europe, especially, but lately. It's called the stress index. And what it is, if we look at the center here, this is called a stress index of 1. You put the patient in volume ventilation, you give them a constant flow, and then you look at the airway graphic. In this case, you've got a linear increase until the breath goes to exhalation. Okay, so that's what you want to see. That means you're getting continuing recruitment. If you get this over here, what's called a stress index of greater than 1, you're seeing the pressure rise, and then all of a sudden you hit this point and it bows up, which means that the pressure is rising for the same amount of volume. And that's usually an indicator that you may be close to being over-distended, because you're not really gaining any recruitment now, but the pressure's going up. The reverse of that may be a stress index of less than 1, which means that the airway starts going up linearly, and then it kind of flattens out. And that means that, well, geez, we might have some room for recruitment there, and you might want to consider adding PEEP. I'm not advocating that we do this. I'm just saying that this is something else that people are looking at, especially in Europe, because they use volume ventilation quite a bit. And it's something that's quick and easy at the bedside that can be used and might apply. And this is not especially, essentially for morbidly obese patients. It's for anybody. But it's something that may be able to be used in this situation if we start seeing recruitment, using PEEP. So, and this is not a non-invasive method. But we've tried it a couple times. We're just getting used to it, so I'm not sure if we're going to continue to use it or not. But just an idea that's floating around out there. So I'd like to summarize by saying that morbidly obese patients, they generally have reduced lung volumes leading to hypoventilation, decreased compliance, increased work of breathing. They have a increased airway resistance leading to those asthma-like symptoms. And again, we don't know if it's truly asthma or if it's the physical alteration of their airways. Non-invasive, it works, especially hypoventilation, post-extubation. You may be able to ward off intubation. That's always good with a morbidly obese patient. Probably the most important thing, though, is the prudent use of PEEP with these patients. And again, use ideal body weight. Do not use total body weight, because then you're at risk for ventilator-induced lung injury. The use of esophageal balloon to measure transpulmonary pressures certainly is helpful. Again, it doesn't come without risk or some training and equipment. But the one thing I want to say is, if we didn't have the esophageal balloon, or even if we did, higher plateau pressures may be indicated, and in fact may be safe in this population if their transpulmonary pressure is low. You're just counteracting the chest wall pressure. So it kind of goes away from our NIH thinking of low tidal volume, low stretch, lung protective ventilation. But in the true sense of the word, if we are protecting the lung, and I think that what's happened with the patients, that the mortality rate's been lower in these patients. We saw that slide where the transpulmonary pressure was only 9 in the obese patient. I think what's happened is, because we've used the lung protective strategy, it's super lung protective in those patient populations. And they were able to survive their, probably hypercarbia and all the other things. But because we didn't go above 35, their lungs probably didn't see anything above 10 for pressure. So we were probably really protecting their lungs more so than the normal patient. But that's just kind of my insight into that. But anyway, higher pressures may be indicated. Certainly, higher than normal peak levels are beneficial in this patient population. And with that, I'd like to say thank you, and I'll answer some questions.
John, thanks a million. I usually editorialize a little bit at the end of your... And John, if you would turn your microphone off when you're not speaking, that'd be great. I usually editorialize a little bit at the end of the presentation, and I will not do that because we have a couple questions that people need to be answered. But I do want to thank you for a great overview of, and probably the most complete overview of this topic that I've ever heard. And let's get back to... Let's try and see if we can get to a couple of these questions. We only have a few minutes to go here. Let's see. One of the questions, one of the observations raised was a question to you: Are the lower complications of obese patients because we treat them more aggressively with hyperinflation and bronchial hygiene because we assume there may be complications? And he goes on to say that it's difficult to compare obese versus not if other factors don't stay the same. Can you make any comment on that, John? And you have to click your microphone back on.
I would say that the complications are higher in this patient population. The mortality, per se, is, there's a question about whether the mortality is higher, and I would say that it's possible that we certainly go overboard. I hadn't addressed that with bronchial hygiene and things like that. It's quite possible. Although I'm not sure we would do it in this patient population any more than we would do with a COPD patient. But I do think that we kind of use the NIH one strategy fits all, and in this patient population we're being super lung protective with them, and perhaps and they're surviving whatever it is they came in with, and that probably we need to be more aggressive. But I'm not sure about the bronchial hygiene. There's really no studies out there that show that may be the reason. So it may have an effect. I'm not sure.
Okay. Another one of our participants asked about what about the incidence of reflux disease in this population. Any comment on that, John?
Yeah, that's a good question. I haven't looked into it other than it is an issue. Certainly with these patients, I think that they are at risk of developing ventilator-associated pneumonia because the reflux, especially with them being intubated, and even if you're using the bundle, those the aerodigestive tract, if it becomes colonized and that some of those the reflux in that, they're certainly at risk for increased ventilator-associated pneumonia. But I would, there's a lot of controversy about whether we treat that or not with H2, I think it's H2 antagonists. But I can't speak to that directly. I'm really not sure. I haven't seen anything in the literature that would suggest that has a direct effect. I think it probably does, though.
One of our participants made the observation of there's a significantly increased hospital costs associated with this population. And I expect that's probably true because it does take special equipment, and not only that, but I would think that the folks that are having to move these morbidly obese patients, etc., are at higher risk for personal injury as well. Do you know of any studies on that subject, John?
I am not aware of anything, and I'm assuming they're talking about injuries to the healthcare worker, and that's certainly, I've seen it happen in our institution. I'm not aware of any studies that I have seen that it increases. I'm not sure that anybody studied that, although, there's a lot of emphasis on cost effectiveness, and certainly, those big beds and, getting them on the CT scanner, transporting them. There was a study that looked at proning these patients and the effect on mortality, and as I recall, there was no significant outcome. But I'm trying to imagine myself trying to prone, somebody with a BMI of 50 or 55, the issues involved with that and the complications associated with that. And I'm sure there's a lot of back injuries, but I do not know for sure if there's any studies out there that look specifically at healthcare workers.
Okay, well, John, we are out of time today, and folks, I'm sorry if we didn't get to all of your questions. But John, if you would turn off your microphone, please. Okay, I would like to thank all of you for watching this as a live presentation. And if you are watching as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.